This video will cover the primary headache disorders, including migraine headache, cluster headache, and tension headache. These are disorders characterized by moderate to severe head pain, and they do not have an alternative underlying cause, such as the use of a medication or dehydration. Medication overuse headache and dehydration-related headache are considered secondary headaches and will not be covered in this unit. First, we will start by discussing migraine headache. Although migraine headache is the second most common type of primary headache after tension headache, the disability associated with migraine is typically considered to be the most significant out of all primary headache disorders. Migraine affects about 23 million people in the US. It is about 2 times more common in women than it is in men. And the most common age at diagnosis is between 35 to 45 years old. As demonstrated in this graphic, in general, migraine is more common during the adult years of 18 to 65. It is much less common younger than 18 and older than 65. In terms of race and ethnic groups that are affected, Caucasian individuals are affected more so than other race and ethnic groups. There are 2 primary groups of factors that contribute to the etiology of migraine headache, and they can be broadly classified into genetic factors and triggers. Genetic factors are an underlying predisposition to develop migraine headaches. Some of the genetic alterations that have been identified include mutations that affect or alter serotonergic neurotransmission. And this makes sense given the role of serotonin in migraine headaches that you will see in just a moment. Many of the genetic relationships to migraine headache have autosomal dominant inheritance, which means that if one of 2 parents carries a mutation that predisposes to migraine headaches, then there is a 75% chance that one of their offspring will inherit that mutation that predisposes to migraine headaches. Another piece of evidence demonstrating the genetic linkage to migraine is that there's a 50% twin concordance between identical twins. And this suggests high genetic inheritance of migraine pathophysiology. The next group of factors that affect the presentation of migraine headaches are what are known as triggers. These are not factors that lead to the initial pathophysiology or the initial development of migraine headache necessarily. Rather, these are environmental factors that can trigger the onset of an individual or specific migraine headache. Triggers of migraine headaches include increased stress, depression or depressed mood, certain foods and drinks, including things like red wine, beer, and foods that are high in tryptophan content, such as red meats. The menstrual cycle can trigger migraines, and we'll talk more in the next video about menstruation-associated migraines. Loud noises or bright lights can trigger migraines, as can low levels of magnesium and the use of oral contraceptives. Specifically, the type of oral contraceptive that could predispose to migraine headache are multiphasic or stepped estrogen type oral contraceptives. The initial pathophysiologic change that occurs to trigger a migraine headache is overactivity in the parasympathetic nervous system. Multiple afferent inputs carry these parasympathetic signals to the brainstem, where this increased parasympathetic tone then activates meningeal projection neurons, also known as meningeal nociceptors, as well as the trigeminovascular pathway. This leads to the dilation of intracranial or dural blood vessels and also local release of inflammatory molecules in the meningeal space. Specifically, the neuropeptide CGRP, or calcitonin gene-related peptide, is thought to be one of the primary mediators of intracranial vasodilation. To summarize, the initial pathophysiologic step is parasympathetic mediated activation of the trigeminal nerve that results in the release of CGRP and subsequent CGRP-induced vasodilation of dural blood vessels and release of inflammatory molecules. One important thing to note about this process is that many of the brainstem neurons that initiate this process of activation are serotonergic neurons that release serotonin to activate the trigeminal vascular system. This will become important later when we talk about treatments for migraine headache. The reason this process is interpreted as painful is because dilation of dural or cerebral arteries leads to the activation of primary afferent nociceptors. Specifically, these are neurons in the trigeminal ganglion that synapse on the brainstem and eventually higher brain centers like the thalamus, which is considered a relay station for incoming pain signals. Those pain signals are then distributed to multiple cortical areas for processing, which result in the perception of pain in the head. One other aspect of migraine pathophysiology is the presence of aura. Aura are visual hallucinations that may precede the onset of migraine in some individuals, about 25% of migraine sufferers. Although the reason for the initiation of aura is not well understood, it is known that aura is caused by a process known as cortical spreading depression. The best way to understand or visualize cortical spreading depression is to imagine a wave, and that this wave is traveling across the brain, reducing neuronal activity as it goes. In areas where cortical spreading depression has already passed through, there is oligemia, which is decreased blood volume, and also decreased neuronal depolarization. So that's like the back end of a wave that has calmed down and reduced activity as demonstrated on the EEG recording. At the front of the cortical spreading depression, or the crest of the wave, there is hyperemia, which is increased blood volume, and increased neuronal depolarization. That increased depolarization or increased neuronal activation is pushing the release of potassium forward through the brain like a wave that then spreads throughout the brain, causing the visual hallucinations that are characteristic of aura. As you can see in the EEG recording example, in areas where cortical spreading depression has already passed, there is little to no neuronal activity, whereas in areas where the cortical spreading depression wave is currently passing through actually have increased neuronal activity. And it is that increased neuronal activity that leads to some of the signs associated with aura. An individual migraine follows a very characteristic pattern of symptoms, which begins with early symptoms, also known as premonitory symptoms. These tend to be symptoms such as mood changes, fatigue, cognitive changes, food craving, repetitive yawning, neck stiffness, and these are fully reversible neurologic changes of varying severity. That is typically the earliest sign that a migraine is imminent, and those premonitory symptoms can actually last throughout the period of the headache. The next stage would be the presence of aura, which are pre-headache visual disturbances such as seeing stars or sparks, or sensory symptoms like paresthesias in the extremities. And as I said previously, these are experienced by about 25% of migraine sufferers. So the vast majority of sufferers do not experience aura, but a great many do. Next comes the headache, which builds in severity from mild to moderate and eventually to severe. During the severe headache stage, there is characteristic unilateral, which means one-sided, throbbing or pulsating head pain that can last anywhere from hours to several days. The severe headache phase is associated with signs and symptoms that are autonomic in nature, including nausea and vomiting, photophobia, which is sensitivity to light, and phonophobia, which is sensitivity to sound, as well as anxiety and irritability. Finally, the headache resolves after a period of time, and there is also a post-headache period that is sometimes characterized by fatigue or exhaustion, recurrent head pain and neck stiffness, as well as cognitive changes. Migraine headache is essentially a diagnosis of exclusion. The diagnosis or analysis of individuals with headache includes MRI scans, CT scans, EEG recordings, as well as other blood labs for differential diagnosis of other underlying conditions. Once other underlying conditions have been ruled out, there is some specific diagnostic criteria or classification criteria for migraine without aura on the left in table 1, or migraine with aura on the right in table 2. For migraine without aura, which is by far the more common type, the diagnostic criteria include at least 5 migraine attacks that fulfill the following criteria. The headache must last between 4 and 72 hours. The headache has at least 2 of these 4 characteristics. It must be unilateral, throbbing or pulsating quality, moderate or severe pain intensity, and aggravated by or causing avoidance of routine physical activity, like just walking around. And during headache, the individual needs to have experienced at least one of the following: nausea or vomiting, and photophobia and phonophobia. And as I mentioned previously, is not better accounted for by any other diagnosis that would be ruled out or excluded by some of the imaging and electrical recording modalities I mentioned previously. For migraine with aura, there must be at least 2 attacks that fulfill criteria B and C. One or more of the reversible aura symptoms, including visual, sensory, speech, language, motor, brainstem, or retinal symptoms, and at least 2 of the 4 characteristics listed in the diagnostic criteria. As I stated, the majority of migraine sufferers do not experience aura, and therefore it's much more important to study and be familiar with the diagnostic criteria for migraine without aura, which is shown in table 1. The prognosis for migraine sufferers is very good for the majority of patients, especially if a treatment modality can be discovered that works for that individual. Migraine is associated with a very rare but serious neurologic deficit, and therefore response to treatment should be monitored over time to ensure the sufferer is receiving benefit. The next type of headache I will talk about is tension headache. This is actually the most common type of primary headache, but as I said, the associated disability is probably slightly less than that associated with migraine. This graphic demonstrates the prevalence of migraine headache on the top and tension headache on the bottom between female and male sufferers. As we looked at previously, migraine headache is much more common in females than in males, and the maximum prevalence at around age 40 is about 35% in women and about 15% in men. For tension headache, there is not quite so much of a difference between sexes, with females experiencing tension headache slightly more than males, but they are essentially equivalent. The peak prevalence in individuals aged about 30 to 35 is closer to 50% in women and 30% in men. Like migraine headaches, tension headaches are more common in young adult and middle age compared to very young and very old. Tension headaches do run in families, and therefore there is likely a genetic component of this type of headache as well that is less well characterized and understood than that for migraine headache. The pathophysiology underlying tension headache has several underlying causes. Probably the one that is most well understood is the sensitization of nociceptive neurons in the brainstem. Once these neurons are sensitized, they become more reactive to slight changes in the environment, and they signal pain to the cortex and other parts of the brain when they probably shouldn't. Once these neurons are activated, they signal a cascade of pain and inflammation around the head, and this characterizes the typical bilateral hat band pattern of tension type headaches. Like migraine, tension headaches have a slow onset, but the primary difference between migraine and tension headaches is that tension headaches are bilateral, and they follow what is known as a hat band pattern because they typically produce pain in a band around the middle of the head and forehead. Tension headaches are not associated with other features, as are migraines and cluster headaches. This type of headache is episodic, but it may become constant, and it is in that case when treatment is probably warranted. Next, we will look at cluster headache. This is by far the least common type of primary headache and occurs in only about 1 to 2% of the population. As demonstrated in this graphic, cluster headaches occur in about 2% of individuals, compared with migraine headaches and other headaches in about 50 to 60% of individuals, and tension headaches in about 40 to 50% of individuals. The most common group that suffers from cluster headaches are men between the ages of 20 and 40 years old. Unlike the other two headache types, cluster headaches are more common in men than they are in women. There are some genetic linkages to cluster headache, and in general, mutations associated with the development of cluster headache have an autosomal dominant inheritance. Another possible underlying cause of cluster headaches is hypoxemia, which is a decrease in oxygen delivery to the brain. Triggers for individual bouts of cluster headache include alcohol consumption, increased stress, and certain foods. Like migraine, cluster headache is associated with parasympathetic nervous system hyperactivity that leads to activation of the trigeminal nerve, vasodilation of intracranial arteries, and release of inflammatory mediators. But in addition, it involves dysregulation of a specific region of the brainstem known as the hypothalamus. The hypothalamus controls complex circuitry within the brain, and it is a region that is clearly altered during acute attacks of cluster headache. It is not exactly known how the hypothalamus becomes dysregulated, nor how it controls the changes that eventually lead to cluster headache, but it is clear that this region of the brain is significantly affected. One of the main differences between cluster and migraine headache is the association of specific parasympathetic symptoms that include lacrimation or increased tear production, rhinorrhea or runny nose, and nasal congestion. These symptoms are all caused by overactivation of the parasympathetic division of the facial nerve and are very characteristic of cluster headache presentation. The diagnostic criteria for cluster headache are shown on the screen. Cluster headache can be diagnosed with at least 5 attacks that fulfill the following criteria. There must be severe or very severe unilateral, orbital, supraorbital, or temporal pain. What this means is that the pain is unilateral on one side of the body, and it is felt either behind the eye socket, around the eye socket, or near the temple. When untreated, the severe pain will last anywhere between 15 and 180 minutes. In addition, at least one or both of the following must be present. Ipsilateral to the headache, meaning on the same side as the headache, there should be lacrimation, nasal congestion, rhinorrhea, eyelid edema or swelling, forehead or facial sweating, and miosis, pupil constriction. The other possible feature is a sense of restlessness or agitation. Cluster headache has a very characteristic pattern of attacks, where there's a frequency between every other day and 8 per day for more than half the time when the disorder is active. This is considered a cluster bout. A cluster bout typically lasts anywhere from 2 to 3 months and is commonly separated by a remission period that can last anywhere from months to years. Similar to migraine headache, once these criteria are met and other potential underlying causes have been ruled out, cluster headache can be diagnosed. When the cluster headaches occur in those cluster bout periods that I just described, this is considered episodic cluster headache. This is when there are at least 2 cluster bout periods lasting somewhere between a few days to a year and separated by pain-free remission periods of at least 3 months. On the other hand, chronic cluster headache are headaches that occur without a remission period or when the remission lasts less than 3 months for at least a 1-year period of time. Chronic cluster headache is considered more severe and would be subject to more invasive treatment options. Now is a good time to pause and review what you've just learned. Try creating a table to compare and contrast the clinical features of migraine, cluster headache, and tension type headache. Think about how the etiology, pathophysiology, diagnosis, and clinical presentation of each type of headache differs and how it is similar. For help answering this question, snap a pic of the QR code on the screen.